Welcome back. It's Dr. Shilpi Pradhan here. We're going to talk with Dr. Kelley von Elten today. She is a allergy and immunology specialist, a doctor in the Richmond, Virginia area, and she has her own practice. We're so excited to learn about spring allergies and everything from her. Dr. Kelley, can you introduce yourself a little bit more?
Hi, Shilpi. It's great to be here. Thanks for having me. So I am an allergist immunologist, like you said. I originally did pediatrics, and then we can get to allergy through either pediatrics or internal medicine. So we see all ages, no matter what specialty we started with. And yes, I started my own practice here in Richmond March 1st. So very excited and proud. And I have been really enjoying seeing our patients and taking care of our patients in the Richmond area. And always happy to talk about all things allergy, especially with wonderful colleagues like you that also help take care of our patients. And so I'm happy to be here.
Well, we love that you have, to support women-owned businesses and small business too. I mean, people don't think about medical practices as small business, but we are. So
Right?
love
Yep.
to support that, just like we are, my practice as well. So let's just dive right into it. It's spring season, it's May, allergies are strong in Virginia.
Yes.
So
Yep.
maybe we can talk about the common sources of allergy and then the uncommon sources of allergy.
Sure. So Richmond, Virginia, last year in 2020 was voted or was ranked the worst place for allergy sufferers, and then this year actually #2. And so the
What's
way
number one?
this year, I think it was a place in Pennsylvania actually, but you kind of see sort of similar cities in the top 10 every year. And so in Richmond, and for most of the East Coast, and in most places actually, tends to be tree pollen is the spring allergen, and that tends to be what bothers people the most. Here in Richmond, and for much of the general area, oak tree pollen is the worst, and that tends to be what comes up in March and April. And part of what you see with the yellow sort of covering the cars and covering the driveways and everything. And it makes everyone think about tree pollen, even if they don't have allergies. Interestingly, also part of what you see there is pine, and pine is so large that it doesn't actually get into the nasal respiratory tract very well. And so it doesn't actually cause a lot of allergy, but it tends to be a lot of what you see with your eye because it's so large. And so not always is what you see exactly what's causing the symptoms in that time, but it is usually a sign that oak pollen is also out there too. So I would say most people who have a lot of trouble in the spring are allergic to tree pollen. And then that typically in this area is February through May, sometimes early June. Grass pollen season tends to be June through August, and then weed pollen season with ragweed being the big one that peaks around Labor Day and in September, August through October, November, which is usually the first hard frost of the year, meaning that most of the pollen dissipates after that point. And then if we get a little warmer weather, you'll see it kind of come up and down as we get into the winter.
So it's different things throughout different
it is.
parts of the year.
Yeah,
I don't know
it
if
is.
I realized that. That's
Yeah.
so cool. Okay.
Yeah. And so when we think about allergies and we do testing for allergies, if somebody only has positive grass pollen on their skin test, but they have really bad symptoms in the spring, I can't always say that it's from allergy, because if they don't have positive tree pollens, there was no grass pollen in the spring. And so sometimes you can have an overlap of an irritant effect of the pollens, which I know you probably see in a lot of your ophthalmology patients, as well as an allergic mechanism other times of the year. And so we spend a lot of time kind of talking about irritant and allergy and the difference, sort of like when we think about intolerances and other parts of what we do too. So I would say different tree pollens are present in different amounts in different parts of the country, but for the most part, it's not all that different. So I've also practiced in Colorado when I was in the Army, and there the big tree pollen was cottonwood and cedar, mountain cedar. There was a little bit of oak, but not as much. And so we would see those big ones come out in kind of March, February, March timeframe. In Texas, it's notorious for the cedar fever, if you've ever heard of that, in January and February.
Mm-mm.
And that's another tree pollen season. And so it can vary a bit, and in the higher elevations, you tend to see a bit later with the tree pollen. Like we here tend to tree pollen season also. But regardless, for most places, spring is tree pollen season and tends to be what drives people crazy.
So can you define the difference between like an irritant and an allergen?
Yeah, so it's really the mechanism by which it causes the symptoms. So you have IgE is the allergic antibody that we look for when we test. And if you have an IgE, allergic antibody molecule, interacting with the mast cell, which is the allergic cell, and then the mast cell degranulates, opens its contents and releases inflammatory mediators that cause itching, like histamine, which is why we take antihistamine, eye drops, and oral medicines to help with allergy. You have that mechanism which defines and is how we define the allergic mechanism. Irritant is just like it sounds, where it's rubbing your eyes, getting in your nasal passages, and causing local inflammation, but it's not mediated by that allergic antibody. And so
Okay.
it looks and feels just like allergy, but may not necessarily be distinctly in other ways we may not. And so we spend a lot of time talking about allergic versus non-allergic rhinitis, and usually that's more irritant induced. If somebody has itchy, watery eyes, congestion, sneezing, runny nose in the spring, and they have pretty negative skin testing sometimes, then it might be more of an irritant reaction, but to them, it looks and feels just like allergy. And sometimes it responds similarly to medicines, but not always.
That is so interesting. So, I mean, definitely if someone's having symptoms and
Right.
they're not being treated with over the counters, like they need to come see you to figure
Yes, I
out
think
what
so.
is going on and what is the
Yeah,
right treatment, because
right,
it could not be an allergen. It could
right,
not be the common thing that their family member is allergic to, and they may
right.
not respond to the same treatment. So, oh,
Mhm.
okay. So
They
that's
need a
great.
different approach. Yeah.
So do you have some, what are the uncommon allergens like that would just kind of, well, actually, let me ask a different question. What are the mimickers that can mimic allergy that someone should definitely come see you for, that, could be serious if they were ignored?
Oh, good question. So I think as far as the mimickers go, you hear a lot of folks sort of talk about uh, strong odors or perfumes. Are they allergic to those? And that's usually also an irritant type reaction. And there's something called vasomotor rhinitis, which is a form of non-allergic rhinitis, where you get congestion and dilation of the blood vessels inside the nose in response to strong odors. And that can also look and feel just like an allergic mechanism. But we have a separate set of medicines for that tends to work pretty well, like Atrovent intranasal ipratropium, that we'll use sometimes for those instances. Not that that's necessarily very serious, but certainly I think it's helpful to understand the mechanism so we can pick the best treatment. Also, I think as far as mimickers or things that can be more serious sometimes is molds in the background can cause a lot of nasal allergies and respiratory allergies. And I think sometimes identifying those and understanding where they might be coming from is important. Sometimes, no, sir. So when we think about molds and the contribution to some of the people's symptoms, we often identifying which molds are contributing is important, because there are certain things that can get inside the lung and cause more distinct symptoms, like allergic bronchopulmonary aspergillosis, or ABPA. And that is something that can exacerbate asthma, that is an allergic reaction to a mold inside the lungs that can be very serious and that we can treat especially if you're somebody who's had a difficult time with asthma, or typical treatments for asthma aren't working very well. That's when an allergist, or even before that, can help kind of figure out, is there something more that we should be looking at? And a lot of times we can help those people feel much better from that.
I mean, that's super serious. Mold in your lungs, that's super
right.
serious. So definitely something you shouldn't just keep, taking allergy medicines,
Right.
not getting better, like get help from the right doctor
Right.
that knows what they're doing. Okay.
Right.
Good.
And we work closely with a lot of our pulmonary colleagues on that too. And I think between the two of us, it's important to have a sense of the goals for care and exactly what the best management is, because especially if you tried over-the-counter medicines and it's not working as well as we would like. So.
And I was thinking patients with autoimmune diseases, even
right.
something simple like diabetes, but of course, more serious ones like rheumatoid or lupus or some of those other ones would probably be way more prone to an infection that just kind of is lingering, like you suggested, and they could be ignoring it,
Right.
and they just need proper treatment before it becomes a much bigger problem.
Right. Especially with some of the patients that might be on medications that suppress their immune system too.
Mm-hmm.
We take care of a lot of people also with sinus issues or history of pneumonia. And if I sort of put my immunologist hat on and think about primary immune deficiency, or things that we can treat and identify if somebody has recurrent infections or ways that we manage that, that's important to look at and rule out with an allergist immunologist, because if you're getting treated for 6 or 7 or 8 sinus infections a year, that is not normal. And you might feel better a little bit with allergy medicine, but there may be something more significant going on.
That's a great point. I kind of had a side thought. I don't know if you want to get into this, but what is COVID doing to all of your workup for the immune deficiencies and things like that?
Well, it's a good question. We have seen a lot of patients that may have had COVID a long time ago and are still feeling very fatigued or still have residual cough. And for a lot of those patients, we're sort of helping the symptoms of the cough as much as we can. If they had a really bad pneumonia, even though we know that that can be part of the COVID picture, I will still check antibody levels, which is blood testing, to look for immune deficiency, just to make sure that it wasn't sort of the time of unmasking of some kind of underlying disorder. That interestingly, we're not seeing COVID affect our asthma patients as much as we were worried originally. And we actually think that our allergic asthma patients have probably a protective effect, because in their lungs, the receptor that receives COVID, the ACE2 receptor, is down regulated. And so many of our allergic asthma patients have not gotten as sick as we were worried at this time that in 2020 that they would actually. And so, and actually they published a study last summer showing that allergic asthma was not one of the top 5 things that had people very ill in the hospital. And that was a big surprise, because we really thought that our respiratory patients would be amongst the highest risks, and it turns out that they were not. Even a colleague of mine who takes care of cystic fibrosis patients at National Jewish Hospital in Denver was saying that they haven't seen a lot of their CF patients get very sick with it, which is interesting too. So
that's so reassuring.
Yeah.
Wow.
So I think we're thinking about it and always on the lookout for immune deficiency in patients who have unusual infection or who have a really bad pneumonia that took a long time to recover from. And so I think that's always something in the back of my mind that I never want to miss. But I think it's COVID itself hasn't necessarily changed our approach to or other respiratory medications if they're having residual respiratory symptoms. So.
Just from my knowledge and everyone out there listening, what is the most common immune deficiency that you see?
In
just in
adult,
general practice, and then
yeah, in
maybe
adult,
to the point that you just said earlier, the one that's most commonly unmasked with COVID, maybe.
right. So our adult patients, the one that we're always on the lookout for is something called CVID, or common variable immune deficiency. It's not necessarily the distinct one that we find in patients that had trouble with COVID. It tends to be more a diagnosis in adults, and it tends to present with low IgG or hypogammaglobulinemia, which is the main antibody in our tissues and our blood that fights infection, helps us stay healthy and avoid infection. And so IgG can be low in many different immune deficiencies, but when we find low IgG in adults, it tends to be CVID. I have not found anybody who had COVID or had a bad pneumonia with COVID who's had low IgG. I look for it because I want to make sure I'm not missing a reason why they were very ill, but I actually haven't found that yet. I have diagnosed CVID in patients who had Mycobacterium avium in their lungs, which is just another pathogen that is unusual to find in the lungs. So I would say the warning signs tend to be more the bacteria or unusual bacteria that are found, and then they kind of make their way to us. But I do think about, is there an immune deficiency component to some of these people that are having more difficulty recovering? We haven't seen that published in the literature, but I try not to miss it in case that is their sort of initial presentation, you know. And if anybody's going to look for it, it's going to be an immunologist, I think, and that's why I feel like we have to look for it and make sure that we're not missing it. Viral infections tend to be, and we think COVID actually in particular, the T cells, which are a subset of the white blood cells that respond usually to viral illnesses, among other things, those are probably most important in immunity for COVID. And T cells are also important in some ways that the body manufactures antibodies as well. And so we don't necessarily test for T cell dysfunction very routinely because it can be hard to do that test very well. But we're always thinking about it in our patients that might have been very sick, I think. Unfortunately, COVID, we know, can just make people very sick. But when I see those patients, I'm always kind of running through that thought process to make sure that I'm not missing some unifying reason why this patient has been more affected than, say, another patient. And that, unfortunately, the answer is we just don't know sometimes.
That was so interesting. I have two questions to follow up on.
Oh, sure. Happy to help.
So much. The first one, shoots. The second one I'll go with first because I forgot the first one, but it'll come back to me. The second one was, you know, what was talked about early in COVID, the blood types like A type, B type, and, you know, and AB and O. And is there anything that you're looking for with that, or is that panned out to be kind of not as important at all, or does that?
I have not heard that has panned out. Yeah, we have not had guidelines telling us to look at that specifically. Okay. But yeah.
I remember my first question now. So for common variable immune deficiency, other than just like chronic infections and illnesses, are there other signs people should be looking for to, you know, to know when to come see you or have their doctor refer them to you? So like weakness or fatigue or anything else?
Yeah. So those patients, when they present to us, typically have more than 2 to 3 sinus infections a year. That's often how they find us. Or maybe they've had sinus surgery that, for whatever reason, and probably it's their immune deficiency, but they still have a lot of residual symptoms or abnormal sinus imaging. Patients who have had multiple episodes of pneumonia gets our attention. Patients who have been admitted to the hospital for a very bad infection that required IV antibiotics. Patients who have those things, maybe to a more less severe extent, but feel poorly or have had weight loss or have required long-term antibiotics for an infection that just wouldn't clear. Those are all patients that we should see.
All right, good to know. I think we totally deviated from our
I know, from the
original
allergy. That's
like
okay.
allergy and springtime, but I learned so much, Dr. Kelley. Do you want to go back to common allergy and just
Sure.
like your top 3 tips for people to deal with spring allergies? And then if there's anything else, we can add that or we can wrap it up. I so appreciate your time.
Well, thank you for having me. So I think what I tell folks and patients that come see me, whether or not they've tried allergy medicines, is avoidance is our first way of treating all things allergy, right? And so that means if you have dust mite allergy, adding a dust mite cover to your pillow, and there's special ones that zip up and you put your pillowcase over it. And it locks the allergen inside. So when you lay your head down, it can't get to your face. And that's very important for people who are dust mite allergic, which tends to be more common in humid environments. So dust mite thrives in greater than 50% humidity. And so we are very careful to try to get control where we can with that. And that's washing the bedding once a week, which I'm not very good about, but that is part of what the recommendations are for dust mite allergy. And pet allergy, if your pets sleep with you and you have a lot of nasal symptoms around them, that can be problematic. And so I am a pet fan. I have 3 small children, and so I have no room in my life right now for a pet, but I understand that they are members of the family. And so I try to talk with my patients about, can you keep them out of the bedroom? Maybe. I know that can be difficult, but keeping the bedroom a safe space is really from allergens as much as you can is one of the best ways to help you feel better. And going towards the same idea with avoidance, you have sort of, if you have very bad grass pollen or tree pollen allergy and you go out and mow the grass, doing mask and goggles, which actually doesn't look so strange now that we've sort of had this whole period of outdoor masking. That is, we're kind of on the other side of that now, I think, but that can be very helpful. Just keeping that allergen from getting in your sinuses and your nasal passages is so important. And then the other last piece of avoidance, we do a lot of sinus rinses. If people don't mind doing them, like a neti pot or a sinus rinse can really help wash that allergen out so that you're not laying in it overnight and causing sort of localized allergic reactions in the nasal passages. We always recommend distilled water with those, or some kind of, previously boiled water, not just plain old tap water, to prevent rare infections. But those are the big things that we talk about. And then seeing one of us, of course, if typical medications that you might get at the drugstore haven't been helpful. We have allergy shots or allergy immunotherapy, which retrains the way your immune system responds to airborne allergens and our most effective treatment for allergies, and can be truly life-changing for our patients. And so knowing that there is something out there more than what a patient has been able to take or find, I think can give some hope and help people, miss work less and feel better and miss less school. And it's a big commitment, but our patients who do it are really feel so much better. And I think just knowing that that's an option, I don't know that a lot of people are aware of that as a treatment option. And it's not our first choice necessarily if we can do some avoidance things and just avoid our allergens. But if we're not able to, then I think it's a great option that can make a huge difference in how people feel.
I agree. I mean, why not take advantage of all the medical science and knowledge
Right.
that we have and use, experts like you and your colleagues and myself for whatever the problem is. Like,
Right.
let's not live in whatever
Right.
pre-current medical age. So
Right. You don't have to feel bad, right? You don't have to just deal with it. There's a lot of things that we can do.
I've learned so much, Dr. Kelley. Can you just
So,
tell us your practice name and your address and phone number, and I'll put it all in the
sure.
video as well.
Yeah, thank you. So it is RV4, which is 7229 Forest Avenue, Suite 104. And the phone number is 804-285-5000. And we see patients of all ages, and we're like you, we're a small office and we're a family, and we really try to take great care of our patients and listen and do our best to go the extra mile, I think. And I've really been so grateful for the patients who have found us since we've been open, and appreciate the opportunity to serve them. So.
Thank you so much. Actually, you broke up a little bit with that website. Can you say it again one more time?
Oh, no. Oh, sure. Sorry. So the website is rvallergy.com, and the street address is 7229 Forest Avenue, Suite 104. So we're about half a mile from Trico Doctors Hospital.
Excellent. Awesome. Thank you so much. I learned so much, and you know, we use you when we have patients with difficult referred eye pain that's really a sinus infection and all those things. I love the collaboration. I hope we can talk again maybe later, and we can update on COVID again. And thank you so much.
Yeah, thank you so much for having me, Shilpi. I appreciate it. And I have a lot of respect for what you've done with your practice, and I'm just glad that we have a chance to talk like this and have good people that we can rely on for our patients back and forth, because it's so important, you know.
And help our community, our greater community, take care of themselves and
as much
as we can.
Yeah.
All right, have a great day.
Thank you. You too.